And now let me introduce you to the speaker of the last and very interesting topic, Dr. Florencia No. Dr. No is a gynecologic oncologist and the head of the oncology unit at Sanatorio Allende Cerro in Cordoba, Argentina. She serves as the Latin America and Caribbean representative on the board of the International Gynecologic Cancer Society, or IGCS. Additionally, she is a board member of the Argentinian Association of Gynecologic Oncology and the Argentinian Society of Surgery. She is also a member of the Global Expert Advisory Group on Ovarian Cancer, convened by the World Ovarian Cancer Coalition. Dr. No will be discussing in the topic of management of ovarian cancer in low resource setting. Florencia, the floor is yours, please.
Thank you so much for the kind presentation. I'm just trying to check if I can change my slides. Oh, perfect. Well, again, so thank you for the kind presentation. Thank you all for joining us. Here it's the morning, so good morning. I would like to thank also the organizing committee and the Figo Society for the invitation. It's a great honor and pleasure for me to be here today. So we are going to be discussing in the next few minutes the management of ovarian cancer in low resources settings, and this is a topic of growing importance in the community. I have no conflict of interest related to this presentation. And so let's start by addressing why ovarian cancer in low and middle-income countries deserves special attention. First, the demographic burden. 70% of women with ovarian cancer worldwide live in these regions. Second, resource limitations. Third, the financial barriers. The cost of diagnosis and treatment can be catastrophic for women and their families, sometimes pushing them below the poverty line. And finally, there is a knowledge gaps. Limited research exists on the challenges faced in these settings to change the reality for these regions. So here's a brief overview of what we are going to be covering today. First, we are going to look at the global burden and disparities in ovarian cancer. Then I'll introduce the resource-adapted guidelines, evidence-based recommendations tailored to different levels of healthcare resources. We'll then review key findings from the Every Woman study. This is a study from the Ovarian Cancer Coalition. And after that, we'll discuss diagnostics challenges and treatment access issues. And finally, hopefully potential solutions for this global problem. So I would like to highlight first the growing global burden of ovarian cancer, especially in low and middle-income countries. According to GloboCan, ovarian cancer incidence will rise by over 55% by 2050, with developing countries bearing the greatest burden. Mortality is expected to increase by nearly 70%. And this table shows that countries with low Human Development Index not only have lower reported incidence and mortality rates, but this may be due to significant underreporting and limited access to diagnostic and care. So resource stratified guidelines for cancer provide an important framework to standardize care and improve outcomes worldwide. And these are several guidelines addressing strategies for gynecological cancer treatment in the different healthcare systems and settings, So we'll focus on the two more important one, the ovarian cancer, the NCCN guidelines. This is the NCCN harmonized guidelines for sub-Saharan Africa. It provides resources-based recommendations, and they use colors to show different levels of availability. In gray, you can see what strategies may be expensive or hard to use. And in blue, you can find suggestions from the NCCN for regional alternatives when standard care is not possible. And the other one is the ASCO Resources Stratified Guidelines, structure are divided into 4 levels: the basic, the limited, the enhanced, and the maximal, reflecting the range of resources availability globally. These guidelines cover the full spectrum of care, from diagnosis to disease, and specific recommendations for each resource level. So today we'll be referring to these stratified recommendations. But also I would like to share with you some real-world data from the recent Every Woman study. This is an international observational project exploring experience of women with ovarian cancer in diverse global settings, with focus in low and medium setting. The background of this study was the previous study in 2018. This was an online survey where focusing on ovarian cancer patients from high-income countries. And what makes this study unique is that it collects data from both clinicians and patients, including important patient-rewarded outcomes. So combining clinical and patient perspective, the study helps us to better understand barriers and opportunities to improve ovarian cancer care. The study involved over 2,446 patients across 82 hospitals, providing a comprehensive view of real-world challenges. The extensive geographical coverage of this study provides valuable insights into regional variations in ovarian cancer treatment, diagnosis, and follow-up, and also some important points on quality of life. This is an overview of the disease journey, and the challenges in ovarian cancer are many and amplified in low resources settings. And in the following slides, I will try to explore them one by one. So let's start with diagnosis recommendation by the stratified guidelines. Clinical examination should be a basic diagnostic tool, and it has a high utilization rates. However, significant variation exists. In our study, we found that even this no-cost approach is not universally employed. So education and training to general gynecologists and surgeons and physicians globally, it's mandatory. What about biomarkers and imaging? They are key in ovarian cancer management, as we saw in previous presentations. This table shows the ideal adaptation based on resources. ASCO recommends CI-125 in all settings with tiered imaging based on resources. However, despite guidelines, CI-125 access is inconsistent. So let me show you how access is in real practice. As you can see, CI-125 testing rates range dramatically from near universally used in some regions to less than 30% in others, and this is due to cost as the major factor in some. We can find really low access. For example, in countries like Malawi, patients must pay out of pocket, and this really limits its use. About imaging, multiple guidelines support the use of imaging for diagnosis, staging, treatment, decision, and follow-up. These are the recent recommendations from a group from Europe, from Dr. Fischerova and her group. They are all referral radiologists with huge experience in gynecologic oncology. And these guidelines underscore the importance of imaging at every step of ovarian cancer, as Dr. Aina Yami showed in his presentation earlier today. And this group emphasized the use of ultrasound as the initial method, but they also support the use of CT scan or MRI if the ultrasound is not conclusive, or if there is a more accurate assessment we need to do of the tumor burden. What happens in real life, or I have to say in my real life in low and middle income countries, abdominal ultrasound is vital in these settings. It is the most common image percent of the use, although it requires equipment and training and well-trained physicians. And in our study, we found that for many patients, abdominal ultrasound was the only imaging modality performed before surgery. Almost 30% underwent surgery only after clinical exam and abdominal ultrasound, highlighting its importance in these settings. Transvaginal ultrasound offers a superior imaging compared to abdominal ultrasound, but faces, again, significant barriers related to the training of the operator and expertise. And sometimes in some places also there is no availability. This translates into an utilization disparity. In some regions, the report of use of transvaginal ultrasound it's over 80%, and in another settings like Malawi or South Africa, the use is really, really low. So remember also that cultural considerations may be playing a big role, so we need to sensitive think about strategies, implementation for these cultural issues in some patients. About advanced imaging, CT scan and MRI offer valuable diagnostic information, but access again is very in low and middle income settings. Higher enhanced resources, prices are higher, almost impossible without insurance, or maybe they are not even available in some settings. Are always required to travel long distance to find a place to perform these advanced images. The usage rates range from 0% in some countries in the Every Woman study to over 50% in others. Malawi 0%, in Africa 1.7% in Malaysia, and in Latin America the same, less than 50% had access to CT scans. So ALSCO provides recommendations for imaging combination based on resources levels. This diagram illustrates how imaging strategies should be adapted based on the available resources. However, even when accounting for resources stratification, many facilities still struggle to provide the recommended diagnostic workup. So this underscores the need for diagnostic algorithms that account for real world rather than idealized standards. As you can see, cost for diagnostic tests vary widely, but even the cheaper options maybe can be unaffordable. Only 12% of the patients reported that genetic tests were free in their country, and diagnostic tests were free in their country, and 30% of the women reported that these expenses was a cost of family income to fall below basic living needs. So again, when we ask them, what is your top need? They mention free testing, even above free treatment or faster diagnosis. Now let's shift to challenge we faced in providing adequate treatment. As we've seen in previous presentations in this morning, surgery is an essential element in ovarian cancer diagnosis and care. The surgery usually is done for different reasons. The three main reasons is for tissue pathology diagnosis, surgical staging, and in selected patients and well-trained teams, the debulking surgery with the goal of achieving complete cytol reduction. It's the main step to try to provide the better survival. So this is really important. The ASCO resource stratified guidelines acknowledge the limitation in surgical care and provide recommendations based on resources availability. In basic resources settings, due to the lack of resources, the expert panel recommends that patients requiring cytoreductive surgery in the primary or interval settings should be referred to a higher level of care, highlighting the disparity of access. And this is a real problem because we have a lot of difficulties in the referral. The early stage of special opportunity, but also presents challenge in low resources settings. It is important to have expertise in performing surgical staging when appropriate, as Dr. Fotopoulou mentioned. Between 10 to 30% of the patients may face an upstaging, and these resources stratified guidelines also said that the PET-CT is not validated as a diagnostic or staging tool to replace surgery when there is no surgeon with expertise. So if you don't have expertise in this surgical staging, you should refer patients to a higher level of center of care. When young patients are affected by the early stage of ovarian cancer, in selected patients, clinicians, even in the basic level, can offer fertility sparing surgery, always discussing this with the patient and in a multidisciplinary team. But well, 70% of the patients are diagnosed in advanced stage. So cytoreductive surgery represents the cornerstone in cancer management in these settings. It's one of the main barriers. So complete cytoreduction is related to survival. So it should be done in well-trained teams and with a multidisciplinary approach. And we know that optimal surgery rates from 30 to 80% in rich countries versus 5 to 30% in low resources settings. Again, ASCO provide guidelines for surgical management based on available resources. The decision is complex and always based on the comorbidities and tumor burden. The basis setting, the recommendation is always to refer the patient to a higher level of health center, and guidelines for both limited and enhanced resources settings prioritize consideration related to the available expertise in the surgical team. These are results from the Every Woman study. You can see that we found a really good number of complete cytoreduction over 75%, but I should say that we have a big bias. We have a bias in patient selection because we almost included secondary or tertiary centers. In terms of therapy, ASCO provides resource stratified recommendations. Targeted therapy are not recommended in basic or limited resources settings due to access, cost, and the toxicity concerns. In enhanced resources settings, bevacizumab may be offered to selected patients, but with close monitoring. PARP inhibitors are reserved only for well-resourced settings following clinical guidelines. And this highlights a significant gap between that's desirable and what's realistic in low and medium income countries and with ovarian cancer patients. Maintenance therapy after chemotherapy includes bevacizumab and PARP inhibitors, as we've seen in the previous presentation. Showed the delay and the benefit in oncologic outcomes, but maintenance with bevacizumab is not recommended in basic levels due to the cost and toxicity management challenges, and biomarker testing for PARP inhibitors is often unavailable. So this is again another barrier in our setting. These are what we found in the Every Woman study. Again, in some settings, there are no patients treated with PARP inhibitors, as Malawi or South Africa, less than 5% of the patients receive a maintenance therapy with PARP inhibitors. In the recurrent setting, again, the surgery plays a big and important role, and the guidelines recommend that no centers in the basic level perform this kind of surgeries. They need to refer patients to a higher complexity center. In genetic testing, again, it's an important aspect of ovarian cancer care, even in treatment decision. However, the access is also limited. If we can see this reflected in the NCCN harmonized guidelines, they allow to avoid genetic testing when there is no availability. Nevertheless, in some places there is available, but PARP inhibitors are not an option. So again, that's a difficulty in our resources setting. Finally, I want to emphasize that it is really important. The emotional support of our patients is crucial, and we are often lacking these kind of strategies in low and middle income countries. Family support, are essential for quality of life during treatment, as well as reducing the fear of dying and recurrence. Sadly, only 16% of our patients in the Every Woman study receive formal emotional support after treatment, highlighting this critical gap too. In conclusion, so this is a complex problem. Multidisciplinary approach is mandatory, and improving ovarian cancer outcomes in low and middle income countries requires addressing a three-dimensional challenges. The mere presence of diagnostic technology does not ensure access. We have geographic, financial, and infrastructural barriers to overcome. Out-of-pocket cost of testing are a really critical barrier too, so effective strategies must be tailored to local context to improve this reality. So to improve care, we need creative and collaborative solutions, public-private partnerships, probably, diagnostic hubs, training, telehealth, and advocacy are crucial strategies in today. So more research and guidelines are needed, and we are waiting for the publication. These are my acknowledgements, and again, what I only need is I only need one thing to make me powerful. It's education, and it's one of my favorite phrases. So thank you all for your attention.